welcome to the Doctor Trainer. We're going to talk about antibiotics, when to use them, which antibiotics for which diseases, and we're just going to start. This is an overwhelming table, so we're going to take our time with it. We're going to focus on these three pneumonias, okay? So how do you tell and differentiate pneumonias? A lot of it's going to be context. Community. So community-acquired pneumonia, you're going to have patients who come without any risk factors from the hospital setting. So if we're going to go down to HCAP, if they've been hospitalized, if they're on dialysis, if they're a nursing home patient, think hospital-acquired. If you had a patient with a stroke and suffers from dysphagia or had a seizure from alcoholism, from alcohol withdrawal, um, and it's a right lower lobe infiltrate, then start thinking about aspiration pneumonia. If it's none of these things, it's most likely going to be community-acquired pneumonia. Okay? All three of them are going to have fever, cough, crackles, tachypnea. Even foul-smelling sputum may not be very useful, or it's specific for aspiration. Right lower lobe pneumonia is pretty useful when it comes to aspiration pneumonia. It's hard to aspirate into the left lung. But when it comes to lab tests for these, it's really going to come down to the sputum culture if they give it to you. So even if it looks and sounds like community-acquired pneumonia, you really got to take your time and figure out where the money is. And usually the money in these questions are going to be like a sputum gram stain. And if the gram stain is gram-positive diplococci, well then that's probably strep pneumo, right? But if it's gram-negative and this patient has other risk factors like alcoholism and recent hospitalization, even if they say rusty brown sputum, that's where the money is where the gram stain is, okay? And with the different bugs, when we talk about strep pneumo and community-acquired pneumonia, you have H. flu, you have Mycoplasma pneumoniae, and you have Legionella. So strep pneumo, Haemophilus influenzae, Moraxella catarrhalis, those three are going to be considered your typical bugs. Mycoplasma, Legionella, and Chlamydia pneumoniae will be your atypical. And so that's important to differentiate because of how you're going to treat it. If you're going to have somebody who's hospitalized, and that's also important, if somebody's hospitalized, you treat it differently than if somebody's going to be treated in the outpatient setting. So if somebody is going to be hospitalized for these and then Moraxella, you typically do third generation cephalosporin. One good example is ceftriaxone. Okay. And then typically for your atypicals, sorry, with your atypicals, you're going to do something like azithromycin or doxycycline. So this is helpful for your atypicals. One little caveat is if somebody's being treated as an outpatient, and we typically use something called the CURB 65 to differentiate who should stay and who can be treated as an outpatient. So if somebody's not super sick, hypoxic, uremic, confused, older age, typically you can treat them as an outpatient. And if it's a mild pneumonia, you can still treat them with azithromycin or doxycycline as an outpatient. Okay. When we talk about HCAP, so remember this row is HCAP. I'm gonna try a different color. So Pseudomonas, MRSA are your biggest bugs that you have to worry about when it comes to healthcare acquired pneumonia. Klebsiella, and then we'll talk about MDRO or ESBO, but those have a different set of antibiotics, which we'll talk about. But typically, if somebody has been post-op or some procedure done on them, now they're having fever, cough, shortness of breath, then think of Pseudomonas and MRSA as being your top. So when we treat, it's going to be vancomycin that covers the MRSA. So, and then for Pseudomonas, you need something that has anti-pseudomonal coverage. So Piptazo is one of them. So Pseudomonas needs anti-pseudomodal coverage like Piptazo or Zosyn. You can do cefepime, which is a fourth generation cephalosporin, and that's going to be good enough. For anaerobes, you have all of your oral anaerobes. So Bacteroides, Fusobacterium, Peptostreptococcus, um, Strep pneumo can possibly be in there, but usually that's not the one that's being gram stained, and that's not the one that's specifically being treated. So I wouldn't focus on this one too much. Metronidazole or Flagyl, clindamycin, even Piptazo has anaerobic coverage. This is Unison. These all have anaerobic coverage, so they can be fair game. So typically, if I'm in the hospital and I have a patient and I'm not entirely sure, and they're coming from a nursing home and they have a history of stroke, I typically cover them, and you'll see this a combination of different antibiotics empirically until we get a better sense. But it might be like vancomycin and Piptazo. You see that as a common one, but if you're not worried about anaerobic coverage, then you can do vancomycin and cefepime, because cefepime doesn't have anaerobic coverage. Okay, so that's it for pneumonia. Those are like the ways that I would look at it. If we're going to talk about these next two, which are urinary, so we just talked about pneumonia, and now we're going to talk about GU infections or just urinary infections. UTI and pyelo kind of go hand in hand, okay? So UTI, most of the time it's females, but if it's going to be a male, it's going to be because of BPH and trouble with emptying their bladder, okay? Sexual activity is the one very rare scenario that's with your like honeymoon UTI from Staph saprophyticus. And then catheter use can cause what's called a CAUTI or catheter-associated UTI. Those are similar to like HCAP. You know, if we ever do a procedure on someone, there's a risk of hospital-acquired bugs, and so CAUTI can cause that too. And then pregnancy has its own scenario. So if somebody has asymptomatic bacteriuria in pregnancy with greater than 100,000 CFUs in their urine culture, even if they're asymptomatic, since they're at high risk for complications, then you have to treat those patients with antibiotics. Those are the ones. That's one scenario where you would treat asymptomatic bacteria. And the difference clinically between these two, if you're talking about pyelo, is the CVA tenderness. Okay, so that's a very specific finding, and you should be looking for it if you're worried about pyelo. One other thing that I would think about is, so urinary tract obstruction is kind of implying to stones. So if you have kidney stones, those kidney stones can be infected if they're lodged and urine is not able to travel past it. It'll become stagnant, and bacteria love stagnant urine. Urinalysis, a lot of the times are going to be very much the same. Casts, although they are specific, they don't usually put them on test question. And even in my clinical experience, you don't see casts in every single pyelonephritis. So for that, it becomes more clinical if they have, again, flank pain, abdominal pain, not just suprapubic pain, right? Which would be indicative of like a cystitis. The bugs are very similar, so they're going to be E. coli, Klebsiella, and Proteus for all UTIs and pylos. This is the only time you'll see Staph saprophyticus is going to be in your um, honeymoon UTI. And you would typically educate these patients on emptying their bladder after sexual intercourse. And typically the treatment for this is going to be mainstay is going to be nitrofurantoin or macrobid. Um, this is going to be your hallmark, especially if they're not sick. If this is outpatient, then nitrofurantoin is usually helpful. Otherwise, Bactrim is a good one. Bactrim, you have to be mindful of patients who are elderly because this can cause electrolyte abnormalities and AKI. Okay, so you may have seen like a hypokalemia with an AKI after somebody takes Bactrim or sulfamethoxazole trimethoprim. We don't use fluoroquinolones as much anymore just because of their high incidence of resistance in certain areas. And if you're going to use it, just be mindful that it can do QT prolongation and it can mess around with your tendons. So I've seen this where people have tendon ruptures from um, something like Levaquin or levofloxacin, ciprofloxacin, something like that. If they are hospitalized, IV ceftriaxone is a great option. You're going to see ceftriaxone is a great option for a lot of things. We've already talked about pneumonia, community-acquired pneumonia for your typical bugs. And now with somebody who is like, let's say UTI sepsis or pyelonephritis, we like to use IV antibiotics in those patients. And IV ceftriaxone gets good coverage for gram-negative rods being a third generation cephalosporin. All right, let's talk a little bit about cellulitis. So we'll just do cellulitis right now. So cellulitis, we usually focus on two different types, and it's purulent or non-purulent. So purulent or non-purulent, okay? And these imply the different type of bugs. So we usually assume if somebody's purulent that it's MRSA, and if it's non-purulent, it's strep or group E strep. So this can be from skin trauma. Diabetics get something called Fournier's gangrene. Fournier's gangrene, which is kind of a nasty neck fash slash cellulitis of the groin. And IV drug use can sometimes cause cellulitis at the injection site if they don't use clean needles. And then chronic edema is a good one. I think it's an interesting one because if somebody has bilateral lower extremity erythema, edema, you may think that they have bilateral cellulitis, but it's not very common for cellulitis to occur that way. I mean, pathophysiologically, it has to go through a crack in the skin, and it makes less sense for it to happen at the same exact time on both legs. So typically in the hospital setting, when we see bilateral lower extremity edema and erythema, you'll see that sometimes people cover it with antibiotics because they're not entirely sure, but just keep that in mind if it's a test question. It's most likely venous stasis and less likely cellulitis, especially if there is no white count, no fever, no purulence, etc., especially on their test question. So we already talked about kind of the associations with clinical picture. Um, Not much you're going to get from labs in these scenarios. It's really going to be um, so it's mostly going to be for clinical picture for these patients. Again, if it's purulent, think staph, think MRSA. If it's non-purulent, then think strep. So we're right here. Strep if it's non-purulent, staph if it's purulent. And the treatment is as such. So if it's outpatient, if you have somebody who has an abscess with associated cellulitis, think about treating with coverage for MRSA. So that's going to be clindamycin, uh, SMX TMP, and doxycycline. They all have some coverage to MRSA, okay? And if it's non-purulent and if it's just, red, angry, cephalexin, which is a first-generation cephalosporin, has great coverage against skin flora. And so it'll do well with uh, like a strep cellulitis, okay? All right. Now we're going into like a little bit of the weeds here, because a lot of the first infections that I've talked about are the most common bugs or the common type of infections, but you know how boards are, they're going to ask you questions that are not so common. Septic arthritis, think about what type of joint is being affected. Is it the knee? Is it the hip? Those are usually the most common places. And think about risk factors. Again, there's a common theme here with antibiotics that if it's hospital acquired or if there is nosocomial related exposure, then you're going to have to cover for stronger bugs. So again, if they've had surgery recently on that knee, or if they have the prosthetic joint, a metal plastic joint in that knee, you might want to cover them for anti-pseudomonal. And then IV drug use, of course, and then RA. These are just like risk factors for arthritis or septic, potential septic arthritis. So if they're just coming from the community, keep that in mind. That might be a little bit of a different, uh, antibiotic coverage for those patients. It's going to be joint pain, angry, swollen, red, decreased range of motion. Something else that comes to mind is gout. So gout looks very similar. You're going to see even with gout with aspiration, where the money is to differentiate between gout and septic arthritis is going to be the joint aspiration. So even both gout and septic arthritis are both going to have elevated WBCs. But if there's a gram stain, that's going to be much more helpful for septic arthritis. If there are needle-shaped crystals in gout, and they're usually like kind of looking like this. Sorry, zoom in a little bit. So they kind of have this needle shape, and they'll say something like negatively by refringent crystals. But if they're needle shaped, then you're good. This is probably gout. So if it's a um, typical community acquired um, septic arthritis, it could also be strep. So strep kind of sometimes just will randomly pop up in a joint. If it was somebody who had instrumentation of that joint, think of staph and think of Pseudomonas as well. Neisseria gonorrhea if somebody's sexually active. And so vancomycin helps covers the MRSA, and then ceftriaxone usually covers other things like even so ceftriaxone will be helpful for like a group E strep. Okay. If they are at high risk for Pseudomonas, or if you see gram-negative rods in the aspirate and the gram stain of the knee joint or whatever joint it is, then think of Pseudomonas or Pseudomonas aeruginosa. And again, cefepime will be a good option. And cefepime has, anti-pseudomonal coverage. Again, as a reminder, I'm going to kind of try to connect the dots here a little bit more. Um, we were talking about it here. So piptazo can be helpful, and so try to connect the dots. And by the way, this is also going to be your gonococcal. Cool. All right, meningitis. So meningitis, it's usually little kids, like babies, and older adults who are both immunocompromised. Let's try a different color. So age extremes, immunocompromised state. Close quarters, I think of like Neisseria, especially in college students or in the army or something like that. Close quarters. So fever is a non-specific finding, sensitive. If they have nuchal rigidity, neck stiffness, if they are altered in any way, photophobia, these are much more specific findings for meningitis or even encephalitis. So you typically try to get an LP as quickly as possible because once you give antibiotics, it might skew the results of the LP. So LP should be, if you can, clinically it's hard, but if they have a question that says next best step in management for somebody who looks like meningitis, you should get a CT first. Make sure that there's no mass. CT before LP, but then get an LP quickly and then start initiating antibiotics as soon right after. Okay. And if you have a bacterial infection, the glucose will be low and the protein will be high. Okay. If it's a viral meningitis, the glucose may not be low, it might be normal. And if there is blood, so if there is RBCs in the tap and it's not a traumatic tap, then I think of herpes simplex virus. So depending on the situation, the clinical context, most of it, especially for adults, is going to be Streptococcus pneumoniae. If you're talking about college student, Neisseria meningitidis, and then if somebody had like soft cheese or some dairy, especially in elderly patients, think of Listeria. The typical empiric, and these are all empiric by the way, once you get specific findings like cultures and the culture susceptible to, if you get those types of questions, then empiric goes out the window. You have to do more specific treatment for that particular patient. But again, if this is an early, patient just came to the ED with that type of scenario, then empiric treatment you start with first. And vancomycin helps with resistant strep pneumo, not necessarily MRSA in these patients, but resistant strep pneumo. And then ceftriaxone kind of covers the rest. And by the way, if it was HSV, so if HSV, then we'll do acyclovir. All right, working our way down here. So osteomyelitis. Osteomyelitis, I think of diabetic foot infections, sometimes trauma, and then IV drug use. Usually with IV drug use, you think about MRSA, and MRSA can really spread anywhere. It can seed into the spine, it can seed kind of anywhere, cause endocarditis. So IV drug use can be a little bit more like tricky when you're evaluating a question with somebody with IV drug use. They're going to have fever, erythema, swelling. They're going to have not as like bone pain maybe, but it's usually going to be like if it's a diabetic foot infection or a diabetic foot ulcer, they'll have like little tiny spot. It's going to be very inconspicuous, but it's draining pus, foul smelling underneath their foot, on the ball of their foot. If they ask you what's the most or best initial step in aiding in diagnosis, initial step is going to be X-ray, because if you can pick it up on X-ray, then you're good. So initial step will be X-ray. But if they say the most accurate or the most like most likely to establish diagnosis, it's going to be MRI. MRI has the most like the high sensitivity and specificity when it comes to uh, ruling in osteomyelitis. You can get a bone biopsy in some of these patients if you're not entirely sure, especially if they have what's called if they have a positive probe to bone test. So I can put that here. So if they have a positive probe to bone test, so what they can do is they can take a metal probe and wherever that diabetic foot infection is, and if they can hear a clink, like, and they can feel the like hard end of a bone when they stick that probe in the wound, there's a very high likelihood that there's osteomyelitis in those patients. So even if an MRI may be negative, clinically you may still want to treat for osteomyelitis. So your typical ones are going to be staph, and then sometimes salmonella, um, pseudomonas for sure. Okay, and so the way you treat this, you can do vancomycin, but if you're worried about pseudomonas, especially in diabetic patients, you want to do pseudomonas plus cefepime. If it's a non-diabetic with osteomyelitis coming from the community, maybe they had, you know, complicated fracture, open fracture, um, something like that, then maybe ceftriaxone is probably fair. All right, endocarditis. So endocarditis is going to be typical patient's going to have several. It's going to be a longer subacute type of process where they have low-grade fevers. So low-grade fevers and fatigue, and with it's been going on times like let's say 4 weeks, and you got to find a murmur in these patients. There's got to be a murmur somewhere. Of course, you're thinking about your IV drug users. That's what I was telling you earlier. And same thing, if they have work done on their heart, if they had work done on their valves, your treatment's going to be a little bit different. So if they have a prosthetic valve, those are, we're worried about them more than a regular valve, so you might treat them more aggressively, and especially if they have a metal valve. So if they have a metal valve, that is also a concern. So if you remember your findings, so fever, having a murmur, and usually the right side of the heart has slower blood flow than the left. So, having tricuspid or pulmonic valve, murmur or uh, a vegetation on those valves is more like highly likely than on the left side. But both sides are at risk. So you can get ulcer nodes, which are painful. So these are painful nodes on the fingers. You can get Janeway lesions. So Janeway lesions are painless, and they are on the palms. You can get splinter hemorrhages. So splinter hemorrhages that can occur on the nails. You can get Roth spots, which can occur in the eye. So endocarditis can happen and spread kind of everywhere, but those are some specific findings that if you see in endocarditis, you should definitely treat for it. So blood cultures should be positive for these patients, and if they are positive, they're usually very quickly positive because the infection is circulating in the blood at a high rate. And you got to get a TEE in these patients. So if you see positive blood cultures and you have a murmur on exam, or if they do an echo with a vegetation, you still need to do a TEE because that's better for right-sided um, vegetations. Even if you don't see, like let's say they do a TTE, a transthoracic echocardiogram, and it's negative, that shouldn't stop you from getting a TEE because TEE is much more sensitive in picking up vegetations in the right side of the heart. So it's going to be your skin bugs, so staph, strep, so strep viridans. I think of oral, so dental. So if they had a dental procedure done recently, then that's high likelihood. If it's a colonoscopy and they found um, actually, sorry, go backwards. If it's group D strep, or strep bovis or equinus, if you see that, let's say they did a blood culture and it came back positive for one of those things, strep bovis, then the next best step for them is to get a colonoscopy because you have to rule out cancer in those patients. So this is a reasonable initial empiric treatment for endocarditis. So vancomycin covering for MRSA, ceftriaxone kind of covering everything else. If it's a prosthetic valve or a metal valve, you got to think about Pseudomonas. So you got to put them on cefepime. Okay. And we'll talk about bigger guns and nastier bugs in a separate topic. But keep in mind when we're talking about this that it just really depends on the bug itself. All right, let's say if sickle cell, let's start talking about disease associated. So if somebody has sickle cell, what are you supposed to look out for? So they have splenic dysfunction. So you have to think about encapsulated organisms since if the spleen is not functioning, and typical from a, if you're thinking of a sickle cell like pain crisis, you may get fever and you may get a acute chest syndrome type of question. So acute chest syndrome, you have to cover with antibiotics as well. All right, so I'm not going to talk too much about sickle cell itself, but the encapsulated organisms that we think about, so strep pneumo, H flu, salmonella, I believe Neisseria is in there as well. And so these patients are at high risk for resistance, so the vancomycin is for resistant strep pneumo, ceftriaxone is for all the other ones. Okay, and if they are being hospitalized, ceftriaxone is pretty reasonable, especially if they don't have any other risk factors. All right, and again, we can have hour-long discussions on all these, but I'm trying to give you little tidbits. So infections and AIDS, and this is very important. If they have a low CD4 count, that's when you're worried. But if they're just HIV positive and they are compliant with their medications, and they have a CD4 count of 300, 400, 500, um, or greater, they're they're not susceptible to those AIDS-related, AIDS-borne illnesses. Okay, so they're just like everybody else when it comes to the immune system, especially if there's undetectable HIV load, their CD4 count is 400. So those patients, it's very important that you check a CD4 count, you check an HIV viral load. That'll be very important in those patients. If they have something like oral thrush, that's a bad sign. So if they don't give you a CD4 count, having oral thrush and they're not on any inhalers that have fluticasone in it, then I would say that's a poor sign as far as their CD4 count. It may be low. So let's talk about the bugs associated. So if somebody's CD4 count is less than 200, then you think of PJP or Pneumocystis jirovecii. You should also think about Candida. And Candida in the mouth is common. So if it's Candida in the throat or in the lungs, so esophageal candidiasis, that's concerning. If they have a CD4 count of less than 100, then I think of toxo, especially if they have any like eye findings, brain findings. And then if it's less than 50, think MAC, so Mycobacterium avium complex, or even cytomegalovirus, so CMV. By the way, with less than 100, also think of crypto, so cryptococcal meningitis can be at 100. So it's important to know how much their CD4 count is because then it predisposes them to different opportunistic infections. Uh, for PJP, doing something like Bactrim is not a bad idea. Depending on what type of candida it is, if it's just esophageal candidiasis, fluconazole is fine. I mean, if they're bacteremic, just like MRSA, candida can really spread anywhere. It can seed into bone, it can seed into the endocarditis, so it can go into the eye. You can get ophthalmitis from candida. So if it gets to that point, then you treat with different antibiotics other than fluconazole. So you can do like micafungin is a good one, and amphotericin B usually you reserve for second, third line agents. All right, infections in chemotherapy patients. So I specifically think about neutropenic fever or typhlitis is I think maybe more old term used. Most of your immune system lies in your gut, so you never want to do a digital rectal exam on neutropenic patients. And typhlitis is one of those terms. So, and they can have, it's important to get a diff and it's important to get a CBC on these patients to just evaluate for So not only do you get low white count, but if you get an absolute neutrophil count of less than 1500, but honestly, if it's less than 1000, so if you see something like 600 for the ANC, that's very concerning, especially if somebody is septic appearing. And typically, you got to treat for stronger bugs, so Pseudomonas is one of them. Um, and usually, our first line treatment is going to be like cefepime. And if they're stable after 24 hours, then you're good. And if it doesn't get better and they're still having fevers, then you have to add vancomycin. So that's kind of typical for these patients right there. All right, now we're finally talking about MDRO. Okay, so multi-drug resistant organism and extended spectrum beta lactam producing infections. So there's a little bit of a nuance to that, but we're just talking about, you know, nasty bugs. And if somebody's had multiple, bouts of infections and they've had several bouts of antibiotics, these are the patients that we're most worried about because they can develop resistance pretty quickly. So this can be from your typical infections like UTI, pneumonia, that sort of thing. And it's really dependent on the culture. So you won't be able to tell if it's a multi-drug resistant organism until they have done the culture. So gram stain won't tell you, but culture will tell you. And it'll be resistant to several different types of antibiotics. And ESBL is a very specific one. So ESBL, I'm going to tell you which bugs are associated with it. So MDRO can be general, it can be for any type of bug. But when we talk about ESBL, I think of the UTI bugs. So E. coli can produce ESBL, Klebsiella, I believe Proteus can as well. And it's important because these patients, you automatically need to go to the big guns if it's ESBL. So even if it says that their culture in vitro may be positive for something like cefepime, that might be a red herring. So in reality, that actually doesn't do as well in vivo, even if it says it's susceptible in vitro. So you have to go to the big guns. And the big guns are going to be your carbapenems. So your carbapenems are going to be meropenem, imipenem, so anything that with a penem associated with it. And then colistin is a very not, I don't think, tested as much. So it's usually going to be your carbapenems. All right, C. diff infections. So C. diff infection, this one is going to be from recent antibiotic use. I'll tell you if they don't tell you in the test question how to spot it. There's some association with PPI and high risk of C. diff in those patients. But hospitalization, frequent infections, frequent antibiotics. Think about like your MDROs and stuff like that. It's C. diff is one of them that we have to worry about when we're on antibiotics. Usually profuse watery diarrhea, like 5 times a day, 10 times a day, something like that. So the stool has to be positive. And if they don't give you this information, let's say they do a colonoscopy and it shows the term pseudomembranous. So pseudomembranous, especially in an infection type of patient, sepsis, diarrhea, abdominal pain, they do a colonoscopy and they say pseudomembranous, thickening of the walls or something like that, think C. diff. Okay, and C. diff you're going to treat with oral vancomycin. And it's also important to note two things: what their white count is doing and what their creatinine is doing. Because if they are in a mild C. diff where they are otherwise doing okay and they don't have end organ influence, like in the creatinine, then oral vancomycin is okay. If they are on death's door, I'm telling you, like septic shock, hypotension, and they have ileus, you don't hear any bowel sounds, and their white count is 22,000 and their creatinine is 2.5. That's severe, okay? So sometimes we will add metronidazole in those patients. And just to give you a little bit of history, metronidazole used to be first line agent and it's not anymore. Now, if somebody's had recurrent bouts of C. diff, this is not their first rodeo, then you can consider fidaxomicin, although sometimes they're using it as first line depending on where you are. All right, tuberculosis. So TB, they're going to be coming from endemic regions. So it might be in Asia, it might be in Central Africa, where somebody is immigrating from, and they might, so that's what this is for. They might be immunocompromised, and they're just close contact. So they're going to have a chronic cough. This is not something that just happened a few days ago. They might have hemoptysis. They will have weight loss if it's been long enough, and night sweats. Okay, that's like the constellation of symptoms for TB. So PPD testing, they still like to test you on this, so know your numbers when it comes to PPD testing, and it's important to know your numbers in the context of if they're in an immunocompromised state because the thresholds drop for those. Quantiferon gold is not a bad one. And then typically we get a chest x-ray in these patients because if they're exposed, if they're having weight loss, fevers, cough, you want to get a chest x-ray. You want to look for, typically you'll see like infiltrates in the upper airways. And if they do a sputum culture, it's going to be acid fast. And you should look at pictures for this. Acid fast positive. Okay, Mycobacterium tuberculosis is your bug. And then we think about ripe therapy in these patients. So these are going to be your antibiotics. If you ever see any of these options in your answer choices, they're good. You should know about like their side effects. So isoniazid, I believe you're supposed to give B6 to. So rifampin can cause like a red-orange discoloration to the urine. Isoniazid can cause neuropathy. So neuropathy and elevated LFTs or hepatitis. So the neuropathy you try to prevent by giving B6. Pyrazinamide, I think of gout. And then ethambutol, because it starts with an E, I think of the eye. So you can have eye findings in ethambutol. All right, STIs. So let's talk about if somebody's having sexual intercourse with multiple partners, unprotected, maybe a history of STIs. You have genital discharge. Painful or painless ulcers make a difference because if it's painless, you start thinking about syphilis. If it's painful, you think about Haemophilus ducreyi. And if they have pelvic pain, that's a bad sign. So if you're thinking about PID, you need to make sure that they don't have pelvic pain. If it's a run-of-the-mill, just discharge, they're otherwise asymptomatic, most likely it's going to be chlamydia and gonorrhea. And so doing this NAT testing, sometimes in the urine is helpful, but if you can get swab, that might be more helpful. And then RPR is a good initial test for syphilis. And then if you need to confirm it, then doing FT-ABS is also helpful. And then getting HIV on these patients who are at high risk. So your typical bugs are going to be gonorrhea and chlamydia. So gonorrhea and chlamydia. If they are at syphilis, syphilis has its own constellation of symptoms. So it starts with painless ulcers, but it can progress into secondary and tertiary syphilis. So if you were just thinking about run-of-the-mill and you're thinking about gonorrhea and chlamydia in the outpatient setting, this is a perfect option for you, is giving IM ceftriaxone and azithromycin to cover gonorrhea and chlamydia respectively. If they are syphilis positive, so for syphilis, you can do that penicillin. So IM penicillin. And that should be good for those patients. Just remember that syphilis has its own constellation of symptoms. So if you're talking about tertiary syphilis, you can get neurologic findings. So just be mindful of how to evaluate for those patients. All right, Lyme disease. So Lyme disease, you think about somebody who was hiking in the woods, was exposed to a tick. They'll have something like a erythema migrans, a bullseye rash. So that's how it starts. That's early on. You can get arthralgias. Okay. You can also get heart findings. That's my poor excuse for a heart. Let me try that again. So you can get heart findings. So you can get AV blocks. So if it's first degree, it's mild, but if it's third degree, that's more concerning. And typically you need to get ELISA initially and then a Western blot to confirm to aid in the diagnosis. Uh, Getting IgM to see if it's an active infection versus IgG to see if they've had it immunity from it from a previous bout. Borrelia burgdorferi. And treatment for this can be doxycycline, which is really helpful, and or amoxicillin. If they have any severe findings, and severe findings would be like um, neurologic, outside of just like sometimes they can get even cranial nerve 7 palsy, so they can get Bell's palsy from Lyme. If it's beyond that, if they're having confusion, if they're having paralysis, weakness, if they're having third degree AV block, then think about giving IV ceftriaxone. This is just a little nugget of knowledge for that. All right, fungal infections. So fungal infections, usually in patients who are taking steroids. If they're taking like inhaler for asthma, they can get candida. But we're really talking about immunocompromised patients when we're talking about severe fungal infections. And I'm guessing the way that they will, quiz you on boards. So we're going to move. So we're going to talk about the bugs and drugs as much as we can for this lecture. So if it's candida and it's candidemia, that's concerning. That's usually immunocompromised. Aspergillus. Also, if you're talking about a fungal ball that's in the upper portions of the lungs, that could be concerning. And then Cryptococcus if you're talking about your AIDS-defined illnesses. So fluconazole is helpful if it's like oral thrush, if it's esophagitis. If it's in the bloodstream, I would think, like we talked about earlier, mycofungin, amphotericin B is usually like third line. And then if you're talking about aspergillosis, voriconazole is a good option. Okay, if somebody's really, really sick and you need treatment for cryptococcus, then amphotericin B is an okay option. All right, lastly, parasitic infections. So these are patients who've traveled to endemic regions, and if they've had poor sanitation of their food, undercooked meats, and then sometimes immunocompromised. And depending on what we're dealing with, you can get fever, you can get GI symptoms like diarrhea, abdominal pain, itchiness in the anus or rectum area, and then you can get some lab findings for these patients. So if you get a CBC and you get a diff on these patients, look for eosinophilia. So look for eosinophilia in these patients. But you can get stool, ova, and parasites, smears. You can do like a tape test if somebody's having itchy, perianal itching, and then different types of serology tests. But these are very specific. So we have so many different bugs. So I'm not going to talk about all of them in too much detail. But if you have somebody with malaria, malaria usually has cyclical fevers associated with it. Giardia is somebody who was hiking and drinking stream water, and then upstream, one of the animals probably excreted something, and now they're getting Giardia. And these are usually um, like a fatty stool or steraturia. And sorry for my spelling. And then Entamoeba histolytica, I think of chronic diarrhea, so diarrhea for months. And if they see a liver cyst or abscess, something like that, Those are the patients that I think about with Entamoeba histolytica. And then this one, this is a conversation on its own, but you just know your different types of worms that can cause infections. I think they do like to test this a lot. So if we're talking about malaria, chloroquine is a good option. If we're talking about Giardia or Entamoeba histolytica, metronidazole is a good option. And if we're talking about those weird worms, then albendazole or mebendazole are good options. Let me know if you like this. I'll try to do more of these videos. Sorry, this was a very extensive, but should be a nice crash course when it comes to antibiotics for different types of bugs. So I hope you enjoyed, and I'll see you in the next one.